ovaries.
We have two options. The first one is the follow-up, okay, with CR 125, ultrasound, and MRI. This is one possibility. Second one is a bilateral oophorectomy. What is your choice? For option one, could you raise your hand with me? Okay, not more. In the panel, what's your option? Follow-up or surgery? Ah, Mathilde ne dort pas. Okay. For Mrs. Penolorca?
There is no good follow-up procedure validated in the literature. There are a lot of false positive and also false negative from combining biomarkers plus ultrasound. So I think for this patient it's bilateral salpingo-oophorectomy, not oophorectomy. It's very important to remove the tube. Because probably it's there where we have the major possible lesions. But then at what age, it's the second question.
Okay. Because this case is 40 years, what may be a problem when the case is 30 years old. So 40 years, I think we will go for the bilateral oophorectomy. Okay. But the problem if she is 30 years old. So this is your option. This is your answer also if she is 30 years old?
It's an important question because the risk of ovarian cancer is not very high. It's approximately 20%, Pascal?
It depends on several factors. I mean, the first one is the gene. For BRCA1, the lifetime risk of ovarian cancer is ranging from 20 to 50%. So it's a very high risk. Fortunately, this risk appears at the age of 40. Actually, to be completely precise, at the age of 40, the risk exceeds 1%. Okay? For BRCA2, the risk is ranging in the studies between 10 to 20% for women. And again, fortunately, the risk is actually later than 40, and you exceed 1% after the age of 45. So I will say that for this question, in my opinion, again, we have to discuss with this woman. Guidelines are not the same over the world. There is no distinction for me in the NCCN guidelines, and the age of 40 is appropriate for BRCA1 and BRCA2. In France, we used to have guidelines at around 45 for BRCA2. So we can have sometimes, if this woman still wants a child, remember, this woman have a lower as a husband, so this is very important. No, I'm kidding, but it is very important to address this question because taking a 1% risk until the age of 45 is not crazy, and it could be done. On the other hand, if this woman wants to get rid of this risk, we can put on the table the salpingo-oophorectomy. If we want to follow up for a couple of years, we can use ultrasound. That's the only exam that is now in the guidelines. But like Frederic said, there is no proof it really helps. But there is proof, unfortunately, marker doesn't help.
Your opinion, Anna, and after Mathieu?
Yeah, actually, I mean, being her personal history, including breast cancer diagnosis and BRCA2, her risk of developing primary ovarian cancer is a little bit higher than expected. I know there is no consensus of doing bilateral salpingo-oophorectomy, maybe in France not at the age of 40, but some North American standards go for the age of 40. So the key question in this patient is a very detailed discussion with this patient to explain the risk, and if she is agreeable to bilateral salpingo-oophorectomy now, which is at the age of 40, that would be the way.
There's one question that has been in the back of my mind for a long time. I don't know if you have the answers, talking especially to Pascal Pujol. We just mentioned that this patient has a mother, the mother's sister, an aunt, and a grand aunt that have, but we didn't say at which age they had the cancer. With the little experience I have the impression that in families this tends to be around the same ages. They have it at around 40s, around the 50s, around the 60s, for some reason or another. There was the exception. Is this true? Is this not true? Should we pay attention to the family history? Does anyone else in the family, did they all survive or did they die from the cancer? How does this play in a role?
Yeah, I think you're absolutely right. I mean, I start with the major point, which is the gene, but that's another point. Is there more than the age of breast cancer? The question will be, is there any other ovarian cancer in the family history? That will make a power factor to decide. And actually, it's double, because it is also about the perception of the ovarian risk of this woman if she have an ovarian cancer in his family history. Another, unfortunately not used parameters is we don't have so many correlation between genotype and phenotype for BRCA1 and 2, but there is some. And there is a part of the gene for BRCA1 and 2 that give a higher risk of ovarian cancer. But in first, I will put the demand. In second, the gene. In third, the family history, including ovarian cancer, and maybe this small consideration.
Okay, thank you. Now we have the second case, is a big tumor presented by Frederick.
As it's not, it couldn't be expected by the fact that I presented, it's a chemotherapy case.
Okay.
So it's a 30 years old nulliparous woman with medium-sized breast, 90A, and she had a 3 centimeter upper poor right breast lesion discovered by self-palpation. So she has very dense breasts, is nulliparous, and the mammograms were not contributory. And at ultrasound, she had a right breast lesion, and also we found an axillary node. So what is your attitude for diagnosis towards the right breast? FNA, nothing but a control mammography at 6 months, microbiopsy by TrueCut without radiological location, ultrasound-guided microbiopsy, microaspiration biopsy on a dedicated table, or other options.
What do you prefer? The option 1, FNA?
What's the microbiopsy?
What
is the microbiopsy?
A TrueCut.
The TrueCut biopsy.
TrueCut. FNA?
It's written.
Second, mammography after 6 months? No. Microbiopsy by TrueCut? Okay. Few medical doctor. Could you raise your hand? Okay. Fourth, ultrasound to do the microbiopsy.
Yes.
Okay. And fifth, microaspiration biopsy on the table, dedicated table.
No.
No, it's good. It's not a good option. Only it is reserved for microcalcification. And 6, other possibility. Just 1 minute.
Okay, I think we will go to MRI.
What do you think, Mrs. Nagla, in this case?
We have a young patient, 34 years old. We have this Nalli-Bara. This is a risk factor. She's obese, 155 centimeter and 72 kilograms. So I think she's obese, having palpable mass. I will go for the two for MRI, of course, for preoperative MRI to exclude other lesions, multifocality, bilaterality, and also for ultrasound guided biopsy.
Okay. What you choose a habit, Sharif, in this case?
I just wanted to ask why true cut biopsy? Why not fine needle, an ultrasound guided fine needle aspiration cytology? I mean, as long as I'm not going to give her neoadjuvant chemotherapy, and I just want to know if this mass is malignant or not.
Yes,
so
but if you find a malignant lesion and you decide to go to neoadjuvant chemotherapy, you have to do another procedure for the patient. So in France now we do preoperative biopsy for almost all the patients. We do very few cytology except for true benign lesion or evacuation cytology. But when we suspect a cancer, we do biopsy.
Because we surgeons have to pay a very high price for this true cut biopsy, which causes a very big hematoma and which makes our surgery more difficult. So if I'm not planning to give her neoadjuvant chemotherapy, if she's an early case like this one, who will go through surgery, I only need to know if she's malignant or not, and that's enough for me. And then I will do the biological markers on the specimen itself.
I think the hematoma is more when you have macro biopsy, where you have like 20 or 25 biopsies. Here you can have hematoma, but for only 1, 2, or 3 true cut biopsy, you don't have so big scar usually, but it depends probably on the cases.
Also, moreover, the sensitivity of fine needle biopsy is not satisfactory. Core needle biopsy is recommended to satisfy the triple assessment it is recommended by the ACR guidelines and the SOBI guidelines for solid or for palpable breast mass. We have to satisfy the clinical, radiological, and the histopathological examination in order to be complete.
Okay.
And the second question was about the node. What is your attitude toward the node? Do you do FNA? Do you do nothing? Do you do ultrasound guided microbiopsy or another option?
Okay. FNA for the node. Okay. Nothing. Okay. Ultrasound guided microbiopsy. Microbiopsy? No. Okay. Other. Could you explain you? MRI.
Okay. You don't wait to, I think it's better to have an histology before starting the MRI, but you can do it when you want, MRI, as you want. It's
no place, no?
For the axillary lymph nodes? No. We have to do, I think, from my point of view, we have to take microbiopsy or core needle biopsy using the 14-gauge needle, 2 passes from the axillary lymph node. The value of this in having pathologically proven breast cancer, 2 things. If the node is positive, we will go directly for axillary dissection. If the node negative, in case of node negative, we will go for sentinel node biopsy. So I think microbiopsy in the diagnostic setting is very important.
For the node, you mean? Mm-hmm. For the node, we do cytology in my institution. But,
what do you think? Fine needle aspiration.
Okay.
For you?
We do fine needle aspiration, but once again, it's not mandatory to look for the node, but in an option of neoadjuvant chemotherapy, it's very interesting to have the information, because if it's positive, clearly you go for axillary dissection. And also, I think the biopsy is important also for this patient, in case it's a tumor, for the installation of a clip that could be useful in the future for the evaluation of response. So she had microbiopsy, true-cut microbiopsy in the breast with 17G. It's an invasive ductal carcinoma, grade 3, triple negative, with a high proliferation. The node, we had cytology, so it's a neoplastic cells, so the node is positive. It's a PT2 N1 MX so far with the procedure we have made. If you want to comment on the aspects of the nodes.
Nagla.
This diagram shows how we interpret the axillary lymph nodes by mammography. In the first image.
Okay. So, what do you suggest as a preoperative assessment? Breast MRI, thoraco-abdominal CT scan or thoraco-abdominal evaluation, bone scintigraphy, brain MRI, PET scan or other options?
Okay. We have several possibilities. Okay?
Yes, you have. It's a multiple choice.
We have a few time. I think it's better to ask two questions. The first one is a classical assessment. It is a CT scan, lung, liver, and pelvic health, CT scan plus bone scintigraphy. Okay, it's classical. Could you raise your hand for this proposition, for this option? Okay. The second one is the PET scan. Who vote for PET scan? Mr. Nehmer, okay. And for brain MRI now.
Breast MRI plus other evaluation. Brain. Brain.
No, okay. Mr. Nehmer, could you explain your position?
PET scan, yeah. She's young, she has a triple negative tumor, so PET scan could be a solution.
Mr. Clough, your option here on the PET scan?
I'm not a nuclear medicine doctor, but from what they tell us, the sensitivity of the PET scan is related to the volume of the metastases. And if you have small metastases, you might not pick them up on a PET scan. So even though more and more doctors prescribe PET scan as an initial evaluation method, I think it has still not been demonstrated that it's more reliable than the thoraco-abdominal CT scan and bone scintigraphy. So the radiologists and nuclear medicine doctors are fighting over that matter, but in France it is still a recommendation to do CT scan.
Okay. Matti, what is your habit in Switzerland?
We would be conservative. We have been discussing a lot about the PET scan. The problem with the PET scan is, as Krishna said, that we shouldn't believe it's going to really pick all the lesions. And for the bone, it was initially suggested it was good, but actually we see lots of bone lesions which are completely silent on the PET scan, and that has been now very well described. So we would go for 2 and 3, but I would insist on the breast MRI. This lady has dense breast, she's young, nothing was seen, and something can be hidden either in the same breast or in the other breast.
Okay. Sheriff?
Yes, I just want to warn the doctors here that we do not want to overdiagnose these patients. The latest NCCN guidelines of 2014 do not recommend metastatic workup for lesions that are smaller than stage 3A. And they only recommend metastatic workup when there are symptoms that suggest presence of metastases, like bone pains or coughing, or otherwise normal standard investigations are the only one that are recommended. Now, as regards the breast MRI, this I would also recommend. but not bone scintigraphy. If alkaline phosphatase is normal, if she doesn't have any bone pains, I wouldn't go for that. She's a T2N1 tumor. She's a very early case.
Yes, but she's not a classical T2 tumor.
With the triple negative, it's a high grade, high proliferation, I'm sorry, but the case is triple negative, very aggressive to the Professor Namer asking for PET-CT, so we are afraid from the biology, Dr. Sharif, for this case. It is an aggressive case. The proliferation index is very high, and the patient biology is very aggressive. So we must search for metastasis for this case. I am with the standard, the CT, but if someone asking for PET-CT, it is not recommended, but it's okay.
Okay. Last question.
I was just about to mention, actually, this is a very high-risk patient, being grade 3 triple negative young patient. So I think she needs a thorough metastatic workup, including CT and bone scan. PET scan is not in the recommendations and could be ordered according to the discretion of the physician itself.
It is a difficult question. I think it's better to continue.
Yes. So in this setting, of course, breast MRI is really important to evaluate multifocal and multicentric lesions, contralateral lesions, and to make an evaluation of therapeutic response if neoadjuvant treatment is decided. So we discovered another lesion in this patient on the left breast, as you can see here. So this is the right breast and this is the left breast. So here, for discussion purpose, we take two hypotheses. Hypothesis 1, we biopsy the lesion in the left breast, and in fact it turns to be a multicentric ductal carcinoma, completely different, a grade 2, ER positive, HER2 negative with a low proliferation. So in this case, so we have right breast in a young patient, 34 years old. We have a 3 centimeter triple negative tumor, high grade, with a positive lymph node. And on the other breast, we have a multicentric tumor that is grade 2 and hormonal receptor positive. So we can go through the treatment options. First treatment option, right, a mastectomy plus an axillary dissection, and left, a tumorectomy, because it's multicentric, not multifocal, plus sentinel lymph node biopsy. So maybe we can vote for that and then go to...
Okay. Now we vote for the option 1, surgery. Okay. Second one is...
the second one is bilateral mastectomy,
okay,
right axillary dissection, and left sentinel lymph node.
And the third one is neoadjuvant chemotherapy. Yes? Neoadjuvant chemotherapy. Okay. And for the panelists, from Mr. Kandil, Mr. Nemer, Mr. El Ghazali. Ghazali, first one.
I'm with neoadjuvant chemotherapy in triple negative disease. There is many data that the outcome and survival in those patients who are achieving pathological complete response have a better overall survival than others. So I'm with the neoadjuvant chemotherapy in this case.
Mati, Kandil, and Mrs. Mokhtar.
I would also go for the neoadjuvant chemotherapy, realizing, however, that on the other side it might not have a very good response.
We'll go for neoadjuvant chemotherapy.
Okay. We continue.
There is a question, another...
Sorry, Mrs. Mokhtar.
In fact, yes, we go for the neoadjuvant for a simple reason is not so many places or people can do the sentinel node biopsy. It's not popular in many areas, so neoadjuvant is the best. And again, you can, after the neoadjuvant, consider the efficacy of treatment, whether it is a complete PCR versus node, and score the reactivity according to the Miller score and so on. So it gives also a prognostic indication for what happened.
Okay.
From Mr. Clough, in this case, Krishna, do you think the neoadjuvant chemotherapy is important to reduce the tumor and to do conservative treatment and to know the prognosis of this patient if we have a complete response, pathologic complete response?
We discussed about the advantage of knowing if she's a complete responder. I don't think we discussed about the feasibility of conservative treatment. She has a large cancer on a small breast, so if you operate her now, it's a mastectomy. If you give her pre-op chemo, her probability of having a response that allows you conservative treatment is somewhere around 50-70%, as the tumor is unifocal. So even though she might not demand conservative treatment, by proposing pre-op chemo, you still have that option. So I think, should it be for a past response or surgical options, pre-op chemo is the best option here.
Okay, we continue.
So this is some aspects of she received neoadjuvant treatment, and in fact you have the aspect of MRI, because MRI here it could be also a very interesting tool to follow the response.
Nagla, could you explain
what we
this
see here?
slide?
In the first, before chemotherapy, we can see the mass-like lesion showing intense enhancement of contrast. And if you can see the curve, the time intensity curve, you can appreciate the washout, rapid rise of contrast, followed by washout, the other one, the other curve. Yes, we call it type 3 curve, rapid rise, rapid washout. This type of curve has very high sensitivity for malignancy. After chemotherapy, you can see the reduction in the tumor size and decrease in the tumor perfusion, and the change in the type of curve. Now it is 75% in saturation. The curve changed from being type 3 curve, rapid rise and rapid washout, to a slowly rising, steady curve, type 1. We call it type 1 curve. So I think it's a good responder, very good responder.
Okay.
Chemotherapy.
Okay.
Now
so
we have,
what type of neoadjuvant chemotherapy? Go ahead,
yes.
Mark.
Now we have a question for medical oncologists, no? The first option will be Trifec and followed by Tritaxatia, the classical packs. Second chemotherapy, 4 and 4, okay? After this patient is triple negative, what do you think about the cisplatinum protocol, okay? And I don't know, the fourth possibility is another chemotherapy. I would like to ask the question at Tamé Nahas.
Premièrement, je n'ai une petite. I would have a small suggestion. She's a very young lady, and with a bilateral and a triple negative disease. My question for Professor Pascal: would you go for a BRCA1 and BRCA2 gene? Okay.
Don't anticipate our question.
It's a very good question. Coming soon, coming next.
Yes, great. So my suggestion would go for classical anthracycline sequential taxanes. The question between 3 and 4 depend upon the efficacy and the toxicity of the treatment. Well, if I'm having a very good efficacy of the treatment with the anthracycline, I would push to 4. If my patient is having a lot of toxicity with a very mild efficacy, so I would rather go to 3 and 3.
No platinum protocol?
Platinum in the neoadjuvant setting, well, no, I won't go for a platinum.
And for the panel, 3 and 3 or 4 and 4? Mr. Candil?
Well, I will